Overflow urinary incontinence will be our topic of discussion here. So we have a 29-year-old G1P1 woman who presents to the clinic due to urinary incontinence 3 days after being discharged from the postpartum unit. She says that since she returned home, she's experienced difficulty with initiating and maintaining a stream, but has persistent dribbling of urine into her pants, which has persisted into the night. 5 days earlier, she delivered a healthy 7-pound, 10-ounce baby boy via uncomplicated spontaneous vaginal delivery. It was uncomplicated, and she received an epidural approximately 8 hours before delivery. The second stage was slightly prolonged at 3.5 hours. Her recovery was normal, and she was discharged at postpartum day 2. She is otherwise in excellent health. Physical exam reveals a palpable bladder. Vaginal exam is remarkable only for first-degree perineal laceration, which has been sutured and is healing properly. All right, what do we want to do for this patient? Well, it would make sense in any patient with new complaint of urinary incontinence to get a urinalysis. Certainly you can do it in this patient. However, the fact that she has a palpable bladder and is having difficulty maintaining, initiating and maintaining a stream really points us towards one very likely cause, and that is overflow urinary incontinence. And so what we want to do is get a sonographic bladder scan, and the reason we want to do this is because we want to know what her post-void residual is. And what a post-void residual is after you urinate, there's going to be a certain amount of urine left in the bladder. Okay, you never really get all the urine out. However, you should get almost all of it out. So you shouldn't have more than 50 milliliters of urine left in your bladder after you urinate to the best of your ability. Now, we already know that she is not able to urinate to the best of her ability. She is having difficulty initiating and maintaining a stream, and she has a ton of urine in her bladder. Okay, enough urine in her bladder that's palpable. You get a bladder scan, you find out she's got 700 mils of urine in her bladder. So she certainly is not urinating properly. And this likely, because of the fact that she has this dribbling of urine persistently, this is almost certainly an overflow urinary incontinence. So what caused her to develop this overflow urinary incontinence? Really, what is overflow urinary incontinence? What it is that the bladder fills up and you're not able to urinate properly. And so over time, as the urine accumulates in the bladder, the pressure in the bladder rises. And that pressure in the bladder will reach a point where it exceeds the pressure in the urethra. And so your bladder is not going to explode. Okay, my mom always told me I didn't like to go to the bathroom at school when I was little. My mom always told me your bladder is going to explode someday. It doesn't happen. What's going to happen is if you don't go, you will start to dribble urine out. Okay, because the pressure in the bladder begins to exceed the urethral pressure, and that's indeed what happens here. So because she's not able to go to the bathroom properly, she's not able to urinate properly due to probably some issue with the detrusor, she's dribbling urine out. And that's consistent with her difficulty initiating and maintaining a stream. It's also consistent with the fact that she's got a palpable bladder and she's got a lot of urine left over. Now, there are a lot of causes of overflow urinary incontinence, but what's behind it pathophysiologically is either a detrusor insufficiency, which is bladder hypotonia, or detrusor areflexia, which is where your detrusor isn't working. We call that a neurogenic bladder. In this patient, it is likely a detrusor insufficiency. She received an epidural, and that sort of stuns the nerves. And so it takes a while for those nerves to send their message to the detrusor properly after a period of time. So that's probably what's behind this. Another cause of overflow urinary incontinence, where the detrusor just is not working properly, is post-operative overdistension of the bladder. And that happens a lot after operation. When you're rotating through surgery, one of the things that you really want to know post-operatively, especially within the first 48 hours, is, are you urinating? If so, how much? Are you having any problem initiating, maintaining a stream, etc.? Because it's a common complication after surgery. You can also get this from various neurologic lesions like lower motor neuron disease, spinal cord injuries, multiple sclerosis, and so forth. There are a lot of things that can cause overflow urinary incontinence, but what they all boil down to is that the signal from the nerves to the detrusor is not working properly, and so the detrusor is either hypotonic or it's just plain old not working. And so it's probably the epidural that was behind this. However, there are some other things that that increase her risk. In particular, the fact that she was a prima gravid, and also the fact that she had a prolonged second stage of delivery. That also increases her risk of ultimately developing an overflow urinary incontinence or having bladder complications. And remember that the second stage of labor is 2 hours in somebody who's delivered before, 1 hour in somebody who's delivered before, and 2 hours in a primipara. And you would add an hour to that if they received an epidural. Okay, so just an obstetric note for you there. So this would be a diagnosis of puerperal overflow urinary incontinence, or overflow urinary incontinence in somebody who just delivered a baby. All right, so this will be the stuff we'll talk about. So with overflow urinary incontinence, one of the things that distinguishes it from the other urinary incontinence is that they're going to have difficulty with voluntary voiding. Either they won't be able to void at all, or they can void, but they have difficulty with initiating and maintaining a stream. Just a funny story behind this: when I had my appendix taken out, I swear I had every possible complication I could get. But I had the post-operative overdistension issue. I had a 1.5 liters of urine in me, and I could not urinate to save my life. And I didn't have overflow urinary incontinence, but I was about to. And I can tell you one thing: even though you can't urinate, it is very, very painful once that anesthesia wears off. Okay, you can imagine you need to go, you can't go, you've got that distension, not fun. So if you were to ask her, she would probably tell you that she has some pain or urgency, even though it's not urgency by the clinical definition, where she wants to go but she can't. Now, on the other hand, patients who have spinal cord lesions where they have no sensation from the waist down or below their lesion, they won't have that sensation, but they still will have overflow urinary incontinence. The amount lost is going to be small, but it will be persistent. So she's dribbling out urine throughout the day, throughout the night. The S2 through S4 reflex will be abnormal. It will be absent in some patients, so particularly patients with spinal cord injuries. As far as urinalysis, it'll be normal. They shouldn't have any issues that are stress urinary incontinence related. However, because these patients' bladder pressure is at the very maximum, because it's totally distended with urine, any increase in intra-abdominal pressure will cause more urine to be lost, because you're increasing the bladder pressure beyond the intraurethral pressure. And so they will have some features that look kind of like stress urinary incontinence, because if you increase the bladder pressure, they lose urine, but it's not because of problems with the intraurethral pressure, whereas is what it is with stress urinary incontinence, where they're not transmitting the pressure properly. The problem here is that their bladder pressure is so high that if you do anything to increase it any further, it's going to cause them to lose more urine. Their Q-tip test should be normal, because they don't have any problems with urethral hypermobility. Urodynamically, of course, you'll see a high residual volume, as you did in this patient, and it should be very, very high, not just mildly high. It'll be 400, 500, 600, 700 liters of urine as a residual volume. Okay, now bypass urinary incontinence is somewhat similar. Remember, this is where you have like a fistula, and it's causing you to lose urine. And what's similar about it is how they lose urine. So they lose a small amount, and it's persistent, because if you think about it, fistula, you just have urine coming out the bladder or the ureter, for that matter, into the vagina. With overflow urinary incontinence, it's coming out the urethra, but it's a small and persistent amount. The urine is constantly coming out, and it's involuntary. However, the difference between overflow and bypass urinary incontinence is that with bypass urinary incontinence, they are able to go if they want to. With overflow, because this is a problem with the detrusor, either it's insufficient or it's just not working at all, acontractile detrusor, they're not able to go even if they want to. And if they were able to go, then they wouldn't have their problems. Okay, so what do we see in the history? The causes that can underlie overflow urinary incontinence are very diverse. They can be neurogenic causes, they can be obstructive causes, they can be pharmacologic causes. As we saw with this patient, it was due to an epidural. There can be other causes, psychogenic, cystitis, urethritis, and so forth. So very, very, very diverse set of causes. What you want to know is a neurologic history and physical, because a lot of these causes are neurogenic. That's where it gets its name from. This can be called neurogenic bladder, although that's not the best term to call it because it can be caused from non-neurologic lesions as well. It can also be caused from medications, anticholinergic drugs, alpha-adrenergic agonists, as we mentioned, epidural, spinal anesthesia, and then recent surgeries. As we talked about with the post-operative overdistension, you can get it from that too. So especially if you're going in for like abdominal or pelvic surgery. The symptoms of overflow urinary incontinence will be characterized by a constant, slow loss of urine. The patient will describe an inability to voluntarily void. If they were able to voluntarily void, you wouldn't have any problems here, because the problem is that they're losing urine because their bladder pressure is so high that it exceeds the limit of their intraurethral pressure, and so they lose urine. If they were able to void normally, then you've cut this problem out at the root. So they will invariably describe an inability to voluntarily void. And if the patient is able to void, as we saw in this patient, it will be a very diminished ability to void. They'll have difficulty initiating and maintaining a stream. You can see features of stress urinary incontinence, as we already mentioned. So if that bladder pressure, and it is, if it's at the maximum, the very maximum, then anything that increases the bladder pressure further, like an increase in intra-abdominal pressure, is going to cause you to lose all that much more urine. And so they will have those features of stress urinary incontinence, but it's not due to weakened pelvic floor. It's not due to any problems with urethral hypermobility. It is simply due to the fact that you increase the bladder pressure beyond the intraurethral pressure. Okay, so it's kind of coming from the opposite end here. So hopefully you can see the difference between the two. But they result in sort of the same thing. It's you're losing urine with Valsalva. Typically, there is a desire to void with overflow urinary incontinence, and even can be a serious desire to void where it's almost painful for them, but that's not the case in all cases. Certainly, if they have a spinal cord injury, they're not going to have any sensation down there, so there won't be a desire to void. On physical exam, it's going to be typically unremarkable, but you will, in most cases, be able to palpate the bladder, especially if it's a really thin woman. The external genitalia is normal. You shouldn't note any vaginal diverticula, although that can be difficult to pick up on physical exam. A lot of times you have to do imaging to find that, and this is one of the major differentials. Is the bypass urinary incontinence from overflow urinary incontinence, but I will emphasize that one of the things that will help you differentiate bypass from overflow, even though they both lose urine constantly and into the night, one of the differences is patients with bypass urinary incontinence are generally able to void if they want to, whereas overflow urinary incontinence, they have difficulty with voiding or they flat out aren't able to void. If there's a neurologic etiology like a spinal cord injury, multiple sclerosis, lower motor neuron disease, their bulbocavernosus reflex will be abnormal. So for diagnosis, post-void residual is absolutely mandatory. You need to have this. If their post-void residual is normal, below 50 mils, it's not overflow urinary incontinence. How can you overflow if the bladder's not full, right? So the post-void residual will be very, very high. Now, what can be behind this? A lot of things. Post-void residual doesn't tell you anything. If urinary obstruction is suspected for one reason or another, that can be things like after surgery. You can get post-surgical urethral obstruction if you're doing surgery in the urinary tract. It can be pelvic masses. It can be fecal impaction. A CT can be helpful to identify the site of obstruction. CT urography has gradually replaced IV urography as the preferred test for detecting urinary tract obstruction. Urodynamic studies would reveal a lack of involuntary detrusor contractions despite a large volume of urine in the bladder. So the detrusor is not working the way it should. It's hypoactive, and this stands in contrast to urge urinary incontinence, where the detrusor is hyperactive. The causes are vast. We already went into them, sort of, but it's always due to either detrusor insufficiency, bladder hypotonia, or detrusor areflexia, or bladder acontractility. There are obstructive causes, and so in that case, it wouldn't be due to the detrusor. So that would be like if you had a mass up against the urethra, where you can't empty the bladder, then in that case, yes, you can get overflow urinary incontinence from that. But typically, this is going to be due to a detrusor problem. So neurologically, it could be due to lower motor neuron disease, autonomic neuropathy, that can come from diabetes, multiple sclerosis, spinal cord lesions. The obstructive causes, so pelvic masses, fecal impaction, urethral stricture. There are iatrogenic surgical causes, postoperative overdistension, post-surgical urethral obstruction, pharmacologic causes, anticholinergics. So those anticholinergics we give for urge urinary incontinence, typically we dose them properly, but if they were to take too much, then their bladder just flat out then would not work properly because they're tipped the other direction. Alpha-adrenergic agonists, calcium channel blockers, opioid analgesics, epidurals. And then, like in this patient where there's a propural overflow urinary incontinence, there are some risk factors: prima parity, prolonged second stage of labor, epidural, she had all three of these. Then also instrumental delivery and C-section. How do we manage this? Well, there's really nothing we can do medically. What we need to do is treat any underlying cause, and then we need to relieve the overflow. So if it's permanent lesions, these patients will need long-term intermittent self-catheterization. And if they do need it permanently, then you can place a suprapubic catheter, and that is useful for these patients because it reduces the risk of urinary tract infection. If there's an obstruction, then you can do surgical correction to relieve the obstruction. Now, this patient in particular, she does not have any kind of permanent overflow urinary incontinence, so you can manage this with just intermittent self-catheterization until this goes away, because it will go away. But it will take some time, and so reassurance can be useful, but you really do need to drain her. So do intermittent self-catheterization. Remember, if you have excess amounts of urine in the bladder, that's going to transmit that pressure back to the kidneys, and so you wind up at risk of post-renal failure. So you want to make sure that you're draining these patients out. Okay, so hopefully you have an idea of overflow urinary incontinence. Pretty easy in principle. The things that make it stand out are the fact that these patients have small amounts of urine that are persistently leaking, and then they are not able to voluntarily void. If they have neurologic lesions, like lower motor neuron disease or spinal cord injuries, they will often have an absent or abnormal S2 through S4 reflex. Their urinalysis should be normal. Their Q-tip test will be normal. If you were to, for some reason, think stress urinary incontinence, remember that they do have some features of stress urinary incontinence, but with stress urinary incontinence, those patients are able to voluntarily void, whereas with overflow urinary incontinence, they're not. The high residual volume is what's going to really help you out here, and that's done very easily. You just get, there's specialized machines that do bladder scans. You're not taking like your normal sonography. You use this sonographic machine, and what it will tell you is the amount of urine that's in the bladder. That high residual volume will really point you towards overflow urinary incontinence. As far as management, catheterization is useful. Oh, I didn't really go into this. You can use cholinergics. The drug is called bethanechol. You can use that to help as well. So bethanechol or cholinergic is useful for overflow urinary incontinence, namely for patients like what we saw here, who don't have any kind of neurologic lesion. The problem is more a reversible cause, so a pharmacologic cause. So these cholinergics can be useful for them, and it wouldn't be permanent. So hopefully you've got a good idea here of overflow urinary incontinence. If you have any questions, go ahead and let me know. Otherwise, I encourage you to watch these other causes so you can sort of compare and contrast them. I will see you next time.